Now it's beginning in interventional space. So there are products out there that helps gastroenterologists to identify polyps as an example. Now, as to whether gastroenterologist does it or the machine programs a certain way to do it, I think that will come, essentially linking that intelligence to capability, the dexterity aspect of capability, if you will.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of First Case, we're speaking with Dr. Peter Kim, pediatric surgeon and founder of Activ Surgical. And we're going to be diving into technology in the OR and ways it can reduce medical harm. But we're also going to be really looking at how data can be shared between surgeons and across surgical communities to benefit patients overall, not just specifically for one surgeon, but for anybody to have access to that. And we're going to look at how this data could be democratized. That's a term we're going to hear Dr. Kim discuss. And I'd like the idea of leveling the playing field and making sure that there's access to good information for all surgeons and for all patients to really improve their care and work on reducing that harm for our patients.
Well, Melanie, it's sort of like autonomous driving, right?
Right.
That you're eventually going to get to a point where there's so much data from cars that have been collecting data on what causes accidents that you're not going to have those accidents anymore because people are going to be using the intelligence that's been gathered on that. So I'm really looking forward to talking to Dr. Kim tonight and hearing about where things are going in his area of expertise, and let's get to it.
Yes, let's get to it. We will be right back with Dr. Peter Kim.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Dr. Peter Kim, pediatric surgeon and founder of Activ Surgical. And Dr. Kim, thank you for joining us today. It's a pleasure to have you here.
Same here. Thank you for having me.
We were talking a little bit before the show started, and you told us that most of your friends call you Peter, and we are going to be friends and refer to you as Peter as well throughout the show. And today we're going to be talking about reducing medical harm in the OR with technology and the ways that that can benefit our patients and the OR as a whole. So Peter, why don't you go ahead first, though, and just give us an introduction and a little bit of background on yourself.
So I'm a pediatric surgeon, so I operate or treat surgically children who are even before they're born to about they're 21 years old. And as a pediatric surgeon, the usual sort of areas that we treat are trauma, unfortunately in cancer, birth defects, and then obviously in fetal, and then anything inflammatory such as appendicitis and so on. So I've been in practice for about 25 years. And then over the last 10 or 15 years, I've been migrating into focusing more on technology development and how that can help our current state of care.
So was there something in particular, some impetus that motivated you to be interested in technology and how that could improve things? Anything in particular that motivated you?
I've always been interested in creating knowledge, discovering new things and discovering or learning about nature and how things work. But as over the years I've sort of practiced, it occurred to me that the experience and knowledge in many of these great doctors and surgeons and so on that are simply contained within individuals, even though we take huge pride in our craft, if you will. I just thought that there's a tremendous way to improve on it. So the story goes like this, as in when I was practicing in Canada for a number of years, and then I gained quite a bit of expertise in a disease entity called tracheal stenosis. So these are tiny babies born with a really tiny airway. So it's very much like a breathing through a tiny little straw, if you will. So it's very difficult to breathe in and out, and then obviously any congestion would block it, and then it will be life-threatening. And then over the years, I developed quite a bit of expertise, and I would consider myself a sort of a world expert on that one. And I was getting a lot of referrals from all over the country. And then one particular winter, as I was teaching my son how to ski, he was about 4 or 5 years old, and then I got called about a baby coming over from a place called Calgary, which is about 3 or 4 hours west of a city called Toronto in Ontario. And I was coming down to go to the hospital. It occurred to me that if I didn't get down safely, it wasn't good for me, nor was it good for the baby, meaning that a knowledge or expertise or proficiency that's simply contained within a human being was not a very good way to share horizontally to your colleagues or transmit it to next generation, if you will. So I was thinking about, are there ways in which we can program this into a technology and have it sort of available? So it fundamentally wanted to democratize it so that at any point of care, you will have an access to very best care to anybody and everybody, if you will. So that's how the whole sort of idea about wanting to improve and getting involved in technology started.
I love that. I love the idea of democratizing it, like you said, and making the best care available no matter who it is that's accessing it. I think that's a beautiful way of taking care of our patients as a whole, despite who we are across the healthcare continuum. When we talked also before this podcast, you actually went into like this brief history of like 3 major changes in surgery that kind of got us where we are today. Do you mind expounding on that again and sharing that with our audience?
Sure. So when you look at sort of a history of surgery, there are 3 major things. To me, this is in a personal perspective, 3 major things that have happened, and there's one that's currently happening. 3 major things are: number one is how to control infection, antisepsis. So even just only about in a history of 2,500 years of a surgical history, it's only within last 200 years we thought about infection as a major risk for any type of a sort of invasive procedure. So, that was sort of Joseph Lister and antiseptic technique. So that's a major advance. And second thing that enabled us to do more, sort of a safer surgery, modern surgery, is anesthesia. So before, people used to, if you watch movies and so on, you would drink a whiskey or something, and then somebody will give you a little piece of wood and you bite onto it and they will do a procedure on you, kind of a thing. So barbaric it is. And surgeons used to be barber surgeons in that way. And then obviously the third most sort of a recent thing that's happened is what we call minimally invasive. We used to make a big cut. So the old saying was that, big surgeon, big cuts, but that's not necessarily true anymore. Big surgeons, smaller and less cuts, as in a lot of things are done keyhole and then obviously robotically. But what's happened with a lot of sort of most recent minimally invasive is that now we're starting to go into digital, if you will. So you are looking not directly into surgical wounds, but through a camera system, as an example. And if you have a robot, that's essentially a power tool that's connected to sort of a digital manipulation, if you will. Now you're starting to see lots of digital data of how surgery is done or how surgeons are moving and then what is being done to the tissue. And then if you imagine that, with that kind of a data, you're starting to now learn about those data and then use it to think about artificially how we can do things better or differently. So we're transitioning as a 4th paradigm shift from a natural intelligence to perhaps a little bit of artificial one. Then you're starting to see surgeons and then machines collaborating together in the future.
So the machines are going to assist the surgeon in some ways with how they're performing their procedures. Is that what you're saying? Is it they're augmenting the ability of the surgeon, or is that what you see as the next step?
So there are different ways to look at it. When surgeon does things, so there are 3 components of how surgeon does a surgery. So there's a hand or dexterity component, and then there's a sensing component, as in you would see it, you would feel it, if you will, and then there's a sort of cognition or a judgment component of it. There are lots of tools now as it becomes more and more less and less invasive and more complicated. The dexterity part has been sort of somewhat improved significantly. What really hasn't happened is the way we perceive the operative field. So up till now, essentially, even in a digital sort of a space, whether you use an endoscope or robotic telescope as an example, people are simply looking at using the simple visual spectrum, you red, green, and blue type of a thing. And we really haven't thought about using it beyond human visual spectrum as an example. And then obviously using those digital data to make an intelligence. So currently now, sort of, we are starting to acquire these digital data, but in the future, it wouldn't surprise me that we will start to have some parts of surgery that can be done just as well by robots, and then other parts that can be done supervised by human beings. A few years ago, our team sort of did a first what we call autonomous robotic surgery in an intestine. So, there are two different types of tissue. There's the hard tissue, like bones and brain and so on, that do not really move that much, and then it's not deformable. So it's very predictive. You had an X-ray or CT or MR before the surgery, and that's what you will see at the time of a surgery. But things like an intestine, it's soft, it's mushy, it moves around and so on, and it's very hard for computer vision or these cameras to track. So one of the things we did was to improve on the vision and then a little bit on an intelligence when we were able to do a complex task like an anastomosis, which is putting the two ends of bowel together by programming a robot. The idea wasn't so much to take that over from an expert surgeon, but the fact that by improving a little bit on a vision and a little bit on an intelligence, you can improve on some aspects of technical aspects of surgical sort of a domain. So that was a real sort of improvement, if you will.
That sounds fascinating. And my question would be, incrementally, is that going to improve outcomes for patients? What impact is that going to have on the patients in the future when it's available?
Well, so if your surgeon can see better than how they can see currently, so in other words, rather than just using naked eyes, let's say they are able to see through, seeing invisible, visible, very much like mid-60s they came up with night vision goggle as an example. So now you can see both at nighttime and as well as daytime type of a thing. And so if surgeon is able to see through the tissue while doing an operation and being able to recognize critical structures as an example, there will be less chance of injuring things, if you will, right? And then so those are the kind of things that's only available to expert surgeons, but now you can make that available to any other kind of surgeon, if you will. So I think those enhanced, augmented sort of a visual technologies are coming in. But at the same time, by collecting lots of these, collecting surgeons' experience seeing through those technologies, now you have a sort of a machine learning or a little bit of an intelligence that's able to predict, very much like an experienced surgeon being able to see a little differently than other surgeons, if you will.
So it might be like autonomous driving, where you're doing the surgery, and if you start to make a wrong turn somewhere, the machine would assist with stopping you from doing that. Is that?
Yeah, well, that's a very good analogy. So today's car has a lot more intelligent stuff than the rocket that went to the moon in 1969. So kind of things that allows you to keep you in the lane. Now it has a sort of automatic detection, and it stops on its own. It's beyond the sort of simple cruise control. So at the end of the day, all these advanced safety features that are in modern cars, it really doesn't matter at the end who drives. Cars are very much like a very smart robot now, right? So ultimately it makes you a safer driver. And that applies to, I think, in surgery, all these augmented sort of a computer vision and then added intelligence using that data, that it will make the sort of surgery a lot safer, and then makes everybody, including all surgeons, sort of better surgeons, if you will.
I really like that analogy, talking about, like you referenced back to robots being, really big power tools, but then also the idea that our cars are like robots and they're keeping us safer, and all of it is, improving safety of our patients. And as we're using this machine learning and this augmented or artificial intelligence, what changes are we seeing in how information that it's collecting is being used?
So the surgeon has become gradually, before it was simply using a tool to deal with a particular problem. Now, most surgeons are managing huge amounts of information. So even before surgery, if you need any sort of a visceral surgery, a cavity surgery, you would have had a CT or MR that sort of has a clear idea or informs your surgeon what to expect, if you will, so that your surgeon is not surprised by, simply going in there trying to figure out what to do, as an example. And then in the middle of it, now you're having all these augmented computer vision or advanced visualization that will aid surgeons to be able to see more. And then obviously, when the surgery is done and how the surgery, what types of surgery is done and so on, these are based on patient's characteristics, if you will, based on large amounts of patient information that's already determined. So in that way, the surgeon has a lot more access to information that surgeon did not have before in the olden days. In that, and a part and parcel of that is using sort of a machine learning or intelligence algorithm to be able to support that decision. Now currently assisted, but ultimately I think it will be somewhat predictive and then anticipating, if you will, so prevent something from happening even before that happens.
So will that data be for a particular surgeon, or will that data be collated together for all surgeons to be able to see? Like, if I'm doing a case over and over again and the machine is following me, will it be able to just tell me that I'm doing better at the surgery or identifying where I'm going outside the lines? Or is this something that will translate into something for all surgeons to apply to their practice?
So it will be for all surgeons. So this is how you think about democratizing surgery, right? So what internet has done is essentially, it's sort of a levels the playing field, if you will. A lot of people have access to very, very democratized information. Same applies to surgery as in the olden days. It was simply contained within your own experience and expertise and training and so on. But now it's digitalized. So not only you have access to your own sort of experience that is benchmarked against perhaps other surgeons that have done similar procedures and similar patients, if you will, but ultimately, as the sort of machine learns and handles and more data sets, if you will, there will be time when surgeon would encounter an unusual situation and that machine can potentially tell you, out of 1 million procedures done in this particular way, in this particular situation, these are the potential options you would consider, as an example. So in that way, it allows you to not only make that knowledge accessible, but it's scalable across the entire surgical experience, if you will. And then that's over a period in time, not just this moment in time, but my experience today can be contained and then be shared 100 years later, if you will. And that's part of that sort of accumulation of that knowledge base, if you will, collective intelligence.
So I see how this is going to basically revolutionize surgery in the future. How long do you think it's going to take for this to collect enough data to start making changes in practice? Is this something that's 2 years down the road, 5 years down the road? Where do you see it going?
We are in the beginning of it. I mean, we don't think twice about when Alexa sort of tells you what to do even before you think about it, or even before you could order Amazon, they deliver you like next day kind of a thing, right? So having said that, the places where we're using lots of digital data, whether it's an X-ray space or histology or pathology or radiology, ophthalmology, these are essentially variations of pattern recognition in a sort of a huge volume of data. So in those situations that are already being used, there are products out there that will aid physicians in being able to tell one from the other type of thing. And then now it's beginning an interventional space. So there are products out there that helps gastroenterologists to identify polyps as an example. Now, as to whether gastroenterologist does it or the machine programs a certain way to do it, I think that will come, essentially linking that intelligence to capability, the dexterity aspect of capability, if you will. So that's really sort of beginnings of collaborative kind of intelligence, if you will, right? Autonomy, if you will. So that's coming. I think that's what you're alluding to in a specific intelligence. When is that coming? I think it will come. Likely in my lifetime. People say likely in our lifetime, people will be going to Mars, as in will be multi-planetary species, right? So I'm cautiously optimistic.
I'm so fascinated by this because, of course, when I started working in the operating room, there really wasn't any minimally invasive surgery. It was all still the big incisions. So it's just incredible to me where things have gone in really only less than 50 years. So pretty amazing.
I trained from open era to minimally invasive, and it was very interesting to see in the late 80s and early 90s how surgeons were very quickly adapting not because they were acquiring new knowledge, but because patients were demanding. It was very self-evident that rather than showing a giant scar across your belly to say that you had a gallbladder removed, then you got your neighbor with 3 little tiny mosquito bites and saying, I had the same procedure done. You have to go to somebody who does little mosquito surgery, right? Just overnight change.
Yeah. So I feel like we've learned about, in all the different podcast episodes when we've talked about technology in the OR, we've talked about augmented intelligence or artificial intelligence, machine learning. And now I feel like you've brought in another term, this collective intelligence. And I feel like it makes a lot of sense about this collecting of data and this availability of information, and then talking about seeing it actually coming to fruition in our lifetime and how it's changing surgery. But I'm curious, what are your thoughts on buy-in? Do you think it will be patients driving this use of technology, or do you think surgeons will be jumping on the bandwagon to implement these types of algorithms to improve their practice? Who do you think is going to push for it first, patients or surgeons?
That's a very good question. The Hippocratic Oath would dictate that do no harm, right? Having said that, when you look at, you brought up the example of driverless cars. And then there are 2 different types of risk tolerance you think about. One is tolerable risk, and then the other one is the acceptable risk. People say when in the driverless car space, people will tolerate cars being sort of self-driving cars being maybe about 4 to 5 times better driver than human being. But to accept that, it has to be 100 times or more to be able to sort of safely drive around. Now, if you translate that paradigm into procedures that impacts on your life immediately, your life and death situation, if you will. So you have to think about, how much of that will be sort of, even though it captures your imagination. So I think type of things that needs to be done immediately will be supervised. This is where the collaborative comes in. And the reason why we use tools is to essentially bridge that gap where there are human deficiencies or human variations, both on the patient side and the surgeon side. So I think that's how the gradual sort of adaptation will take place. And then eventually, before you know it, this is how the world changes. A revolution happens. Series of little evolutions, and before you know it, it's new world now.
Goodness, you're right. And it's a new world so quickly. I mean, even like you mentioned earlier with Alexa or with Amazon or my Google search engine, I pull out my phone to search for something, and I know it's been listening to me because it's the first thing that pops up before I start typing is what we were just talking about in the car that I needed to go look up. So I feel like technology is advancing and moving forward, but there is a benefit to using technology to make our patients safer. How maybe more specifically these technologies can make surgery safer?
Yeah. So when you think about collaboration, what does that mean? So the robot, by definition is almost, if you will, it's a replacement of labor or an extension of labor, right? So when you're thinking about collaboration, it means either you need to replace some part of it or reduce the burden that you have, or refine it, if you will. So I think where the initial traction, so for instance, current robotic surgery, even though originally it was invented for cardiac surgery because they thought, doing little blood vessel anastomosis or putting little valves in would be very complex, and who would better to do it than robots, as an example. But where it took the most to sort of, and then the biggest sort of impact was in urologist and prosthetic surgery, because urologists were having really hard time just doing a manual keyhole surgery down in the pelvis in a very deep space. So by having a robot, they were able to transition from big open surgery to a minimally invasive paradigm through robots. So that becomes sort of popularized. And I think, again, whether it's the machine learning or robotic tools and so on, these are all extensions of human capacity and capability. So, it has to serve the ultimate goal, which is to make the patient better and then safer, if you will, right? So I don't think everything will be replaced by a robot or intelligence, if you will, but there will be gradual sort of transition towards, and then there will be period where things will be overlapping quite a bit.
This technology that is advancing at a rapid pace, how do we get hospitals to buy into that technology? What is the outcome that we can look for that's going to be either the cost-saving proposition or the patient safety, patient care proposition that's going to come out of this ongoing changes in technology? And who are going to be the early adopters of this technology? Is it going to be more in the medical center setting, or in the university setting, or in the community hospital setting?
It is hard to know, and it has changed quite a bit, Paul. So in the olden days, you would automatically assume out of 6,000 hospitals in this country, about 1,000 or 1,500 of them would be affiliated with the medical schools or universities. And you would think the knowledge would come from sort of those institutions and then sort of propagated into community and smaller hospitals, and, from an urban to rural setting and so on. Having said that, I think internet has really kind of equalized everything. And then that's number one. And second thing is that it empowers patients in a sense that they have access to information that when I was growing up, we didn't have, if you will, unless, you had a specific interest in it. So sort of patient sort of driven, if you will, demand as to what needs to be done, particularly when they see a benefit in it. I think that's not an unusual paradigm to think about. And this is, I go back to the example of big cuts and gallbladder surgery and then little holes and so on. That really was driven not by surgeons from an academic center wanting to do control studies and, this is the safer way and so on. It's really purely driven by patients who says they saw the immediate benefit, so very much like a parachute. You don't need to do a randomized study.
Yeah.
Some of these things are relatively self-evident, if you will. And then increasingly with transparencies around internet, and obviously danger there is that there are a lot of unfiltered information. But having said that, I trust the sort of a patients and their judgment as to what they think is best for themselves and their family and loved ones. And I think as to how they get adopted, you're right. When hospitals choose certain technology, they look at essentially four things. How big is this sort of burden of illness to our community or sort of disease as a whole? And what really is the unmet need that needs to be solved? And then what is the clinical value? And then how much does it cost? And is it affordable, not affordable? Having said that, things like robotic surgery currently, it's an incredibly expensive tool. And yet it captures people's imagination. We think that it gives you better outcome than manually doing it through keyhole surgery, if you will, right? So, it's again, those are in flux, but again, I think a significant part of it, and increasingly more and more, will be driven by patient demand.
I have one more question kind of to follow up with that. As you were talking about that, I got to thinking about the disparity sometimes in our rural communities and rural healthcare compared to urban and academic medical centers and cutting edge versus people who struggle sometimes to have maybe 10 years ago's cutting edge because they're just availability and cost. Do these technologies and the collective intelligence and the algorithms that we've been talking about, does it matter if a rural community or urban hospital, does it matter? Are these technologies limited to certain areas of the country, or is this something that anybody will really have access to?
So I'll give you a very good example and very recent example of AI. We talked briefly about the algorithms that detects polyps and colon polyp detection. There was recently the Canadian healthcare system is socialized, right? It's a government-run system. Province of Nova Scotia, the state of New Brunswick, bought this algorithms for their hospitals because they lack number of doctors, if you will. So by having access to this kind of intelligence, at the end of the day, it becomes more cost effective because they'll miss less polyps, and then the patients will benefit because they are treated earlier. And then types of sort of experience or volume that's required by their rural doctors, because they do far and fewer cases, if you will. They don't need that anymore because now it's supplemented and collaborated by these algorithms, if you will. Now, you're right. The key challenge, again, is to not so much keep pushing the technology, but appropriate technology that is cost effective and it doesn't have to be so fancy. But I think, again, I see that data as a sort of real equalizer. And then, it's very much like, in the olden days, computer used to be quite expensive, but not anymore, right? And then I think the same applies to the access to the data and then how that will improve outcomes and safety. I think that will be a significantly sort of a more affordable and cost effective.
That's really good. I like how you put that. I like the data being an equalizer and just improving outcomes. I like that. But this has been a fantastic conversation, and I can't believe that we've already come to the end of our time. But before we go, do you have any other final thoughts or anything you would like to say before we wrap up this interview?
Well, I'm limited by what I do not know, right? But
right.
We all are.
Having said that, future doesn't come to you. You have to make the future. That's number one. And second thing is that I think some of us are old enough to remember in the era before 2007 and the era after iPhone, before iPhone and after iPhone. So there was a big transition from simply a communication era to an information era, if you will. So I think as we move towards from a natural to artificial and collaboration between them, I am eternally optimistic. As a surgeon, I have to be optimistic. Glass has to always, it has to be somewhat half full type of a thing. And then I am excited about possibilities. I'm excited to work with machines, if you will, or data from all my colleagues throughout the history, if you will, that will make me a better caregiver, if you will. And then I'm not shy to ask for help in that way and benefit from it.
I love that. And I think that all of our listeners can really find value in that collaboration between the natural and the artificial and the way it can benefit healthcare providers and also benefit our patients. So thank you so much for joining us today. Thank you for being part of this interview. We really appreciate you being here.
Thank you very much for having me. I enjoyed our conversation.
That was Dr. Peter Kim, pediatric surgeon and founder of Activ Surgical. And we had a fantastic discussion talking about technology in the OR and really building on some of the other conversations we've had already this season about artificial intelligence and machine learning. And I really like this term collective intelligence, Paul. He was talking about this collection of data and how it could be used to benefit patients as a whole, to benefit the healthcare community as a whole. And it's not like it was just information that's being stored for one person to use, but it's there collectively for everyone to take advantage of and to benefit everyone. And I really just think that's a fantastic approach to technology and data making patients better.
Absolutely. And I think that the more you see these different technologies working towards improving the care of patients, it's going to have an amazing effect on the outcome of care in the future. So I'm really looking forward to seeing what happens next in all of this. And I bet you it's not that far off.
Nope, I do not think it is. I think it is really right around the corner, and it will happen, I'm sure, in our lifetimes. We will see these changes be implemented, and it's all for the good, definitely for the better of patients and for the future of surgery. And that is going to do it for this week's show. As a reminder, you can help support us by subscribing to First Case on Apple, Amazon, or Google Podcasts, Stitcher, iHeartRadio, Spotify, or on your favorite podcast application. You can also access bonus content for certain episodes by downloading our smartphone application for iPhone and Android. We would certainly appreciate a rating and review because your feedback is important to the show. On behalf of Paul and myself, thank you for listening to this week's episode of First Case.